Hello, everyone, and welcome to the webcast Aging Out Transition from Pediatric to Adult Care for Rare Neurodevelopmental Disorders. My name is Andre Picard. I'm the health columnist at the Globe and Mail, and I'm pleased to be your host and moderator for the session today. Before we get started, I want to acknowledge that the Globe and Mail's headquarters are situated on the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples. We're grateful for the opportunity to live and work on this land and on unceded traditional territories across the country. One little housekeeping note before we start. Viewers can put their questions in the Q&A box at the bottom, and I will try and integrate them into our conversation throughout the day. We won't have a set aside question and answer period. So today we'll be talking about the often bumpy transition that children with rare neurodevelopmental disorders experience when they turn 18 and they age out of pediatric care. Parents really hate hearing that word, aging out, because it brings so much trouble. Due to the relatively low number of cases of some rare disorders, there aren't a lot of qualified specialists. It can take years, even decades, to build a good pediatric care team and services. And those relationships are really essential. And then when children turn 18, they often lose access to these services they've spent years building up. That means they and their parents have to start all over again. Very traumatic, very difficult. Lots of uncertainty, lots of legwork involved. And today we want to share some strategies and some examples of ways we can help, and of course, ways that the system could change to make the lives of parents and patients a lot easier. We have a great group joining us today to talk about these challenging issues. So let me introduce each of them briefly, and you'll see their titles below their names throughout the session as well. Let me start with Dr. Karolina Gorodetsky. She's a pediatric neurologist with the Hospital for Sick Children. Hi, welcome. Great. Carl Weatherall is director and chair of the board with Dravet Canada, and we'll hear a little more later about what that is. Hi, Carl, welcome. We also joining us today is Annie Thomas Deisman. She's a clinical social worker with Unity Health Toronto, and she works at the St. Mike's site in downtown Toronto. Welcome, Annie. And finally, we have Durhan Wong-Rieger, President and CEO of the Canadian Organization for Rare Disorders. She's joined us on a number of webcasts, and we welcome her back today. Hi, Durhan. And thanks, everyone, for being there. I want to jump right into it because this is a really important topic, a timely topic, and there's a lot to say. So, Carl, if I could start with you, we always like to start with that patient-family perspective. It's all important in healthcare. You're the chair of Dravet Canada. Part of your goal is awareness building. So I want to start by asking you to tell us a bit about the syndrome.
So Dravet syndrome is basically a catastrophic form of epilepsy, and children experience all sorts of intractable seizures, and they have all sorts of secondary deficits as well, seen by multiple specialists. There's a pretty high mortality rate, lots of anti-epileptic drugs that sometimes work, sometimes don't. Naturopathic approaches, CBD, things like that, vagus nerve stimulators, and there's a whole range. It's kind of a spectrum in terms of how the children are. Some are doing very well, and they participate in sports, and others are in wheelchairs and nonverbal. So it covers the gamut. In our case, my daughter, for example, is 23 and is in diapers like a 5-year-old. So it covers the entire spectrum. And they typically have other associated challenges too, such as pediatric gait is a huge issue. There's orthopedic cardiology potential issues with them as well. So it's a whole range of potential issues with these children. They're typically autistic as well, although the primary diagnosis is a neurological, seizure disorder. So in a nutshell, that's basically it.
And it's just one of thousands of rare disorders. And when you put them all together, they're not that rare. About one in 8 children, I think, are affected in some way. So this is a big issue, aging out. So you mentioned your daughter, Alyssa. She was diagnosed about 20 years ago. Now she's in her 20s. Can you tell us a bit about how that aging out process went, how you've survived it so far?
I think you described it very well already, Andre. It's a bumpy road. It's not that seamless. And actually, my daughter's birthday is in 2 days. She'll be 23. So I think a lot of it is for us as parents and for people outside to understand that this journey, it's a lifetime journey. It's not just stepping through the door. A daughter's 18 and therefore you switch. It's a whole journey. It takes decades. And we found it wasn't seamless. We had her orthopedic specialist basically say, I hate to tell you this, you're on your own. In terms of setting up other supports. Our neurological team is excellent. The new team that we have is working fairly well. It's all of the other stuff around it, like the legal stuff related to things like power of attorney, guardianship. We started this process, when she was 16. And then there's issues, potential challenges with CRA, RDSPs. The DTC thing causes challenges. Aging out of school. The challenge we have now is the aging out of school piece. And the bigger one for us as parents, we're aging out as well. And the panel talked about that. Are we really aging out? And that's a bigger challenge because there's not many options out there for our kids. Once we age out, no longer able to take care of our kids. And it's a big issue for us. We're trying to deal with that right now. And the supports we have in the background are great. It's a whole myriad of things. Renegotiating contracts with support workers if they're available, that sort of thing, other agencies. And basically my partner and I have dropped to the workforce early, full time. I'm still working, basically deal with this because it's a huge, huge challenge for us and other Dravet parents.
Yeah, and we'll come back to some of those issues later about the ones people living a lot longer with rare disorders, their parents getting older. It becomes complicated. But I'll get back to now for the aging out at 18 rather than us boomers aging out. So if I could turn to Dr. Karolina Gorodetsky, you're a pediatric neurologist. You see children with some really rare neurodevelopmental disorders from across the country. Could you talk a little bit about some of the challenges they face in the pediatric life, and then we'll turn to the aging out part.
Yeah, absolutely. So I see children with mainly very rare conditions and specifically movement disorders and rare conditions. And as was mentioned earlier, sometimes we do need to see children from across the country. And it's really becoming, as was mentioned, the journey, right? Like we, as a physicians and healthcare providers, were there from the beginning, many, many times since the children were born. And we were there with the families through the diagnosis, through the different challenges and complications that came throughout the years. And we kind of know it, right? Like you've been there. So you see in the different, how did they respond to medications or in what conditions they actually need to be admitted. And in other conditions, it's okay. And this is something that can be managed more at home. And what we see many times is that those conditions, that rare genetic disorders, are seen as more pediatric conditions. And now when they're aging out and getting to the age when they're kind of more eligible to be taken care of in the adult system, a lot of times this is very different for our colleagues who are adult-oriented physicians to see those rare specific conditions. So I think that there are definitely a lot of challenges that can arise from family perspective, but also a lot of from the healthcare perspective for those very rare children.
And you treat a lot of these children from the time they're born, right into their adulthood. It must be a really important relationship, and it must be hard to let go.
Yeah, so really, on the personal level, and I can talk more about that, when we do kind of our transition clinics, it's always very, very emotional for us and also for the families, because to some extent, we are also becoming part of their family. And it's really something that's, you've been there for many times, 18 years, and through a lot of the challenges. And now you almost kind of letting go and taking somebody else to take over and be there for them.
And maybe talk to us about what happens in a transition clinic, because we hear so many stories of kids falling through the cracks, but at sick kids, you try and make sure that doesn't happen.
So as you mentioned, it is a bumpy road, and this is not one solution that fits everyone. And I think that it's very, very different ways that those type of transitions can happen. And thinking about different solutions, I definitely think that's it's really important to have a collaboration with the adult physicians and with the adult clinics to make sure that there will be a transition of patients, transition of information, making sure that nothing is getting lost. So one of the things that, for example, our team tried to implement specifically for children with rare condition and movement disorders, and we have an amazing colleagues from the adult world who will be joining us for those specific clinics that we run usually a couple of times per year when there's an opportunity for both physicians, so for the pediatric part and the adult part, to come together and see the patient and the family together. But I think it also brings an important message of, you see the two physicians, you see your pediatric neurologist, and this is the adult neurologist that's now will be taking over and kind of making sure to get all the information as needed. I know that it's not something that's always available. And also, I was talking only about the neurology piece, right? You need to think about that from all the aspects, like Carl was mentioning, right? So a lot of those children have a lot of systemic involvement. So cardiology, gastroenterology, nephrology, many pieces. And, how do you put all of those pieces together and make sure that the transition goes not only from your specialty, but also from the other subspecialties?
Yeah, I see. Annie Thomas Deisman, you're a clinical social worker. You help people, I guess, on the receiving end, the pediatrics who are moving into the adult care system. What are some of the common worries and concerns that you see in your work when kids are aging out and becoming adults?
So I think Dr. Gorodetzky and Carl both touched on some very key pieces, and these pieces are around families' involvement. And I think when patients have had family members and caregivers as part of their care team closely involved since childhood, since they were babies, this shift to potentially having less of their involvement is really challenging. Now, clearly, our patients that we meet in the adult setting can have different presentations. Perhaps they require having a caregiver for ongoing, and then it's very important to include those parents and caregivers as part of their team. A different group of people are people who may be considered capable and competent and now are able to make decisions on their own, but it doesn't just happen at 18. There is this process and shift where education has to be developed. Our patients have to start to learn to be able to book their clinic visits and order their medications. So when our patients are coming to us, a lot of what we do is trying to allay some fears that patients and families have about how transition looks, and really encouraging patients to understand and families to understand that while we may not be the family that they had at their pediatric setting, we can become like that over time, just like they develop that relationship in their pediatric setting.
And it must be challenging. There's a whole, as Carl said, there's a whole spectrum of disability among this patient group. So some are ready to be adults and some may never be. So how do you juggle that?
So we recognize, like I mentioned earlier, 18 is just an arbitrary number that legally we have to follow. So we have to follow, we have to have these conversations with patients about privacy, around having patients and families involved. But we work with patients and we recognize, and I think the way we look at it is that we say somewhere between 18 and 25, it takes this long at least in order to develop that confidence and that ability to be able to manage all of their care. So we invite our patients to bring their caregivers and their family members to their clinic visits. We also respect their privacy. And if there's something that we want to have a conversation with them that may be considered a little bit more sensitive, we may ask someone to leave the room, but then have a conversation and then invite people back and then share information with them. We're really trying to pass on the message that we want involvement of the people that they want involved in their care, but also recognizing that we have to follow the guidelines set out by the legality of the legal system.
Druhan Wong-Rieger, you work with the Canadian Organization for Rare Disorders, CORD. You do a lot of advocacy work on behalf of patients in Canada, around the world. I want to talk first about some of the barriers to care for the pediatric patients in this very specialized group, and then we'll talk about the aging out part. You're on mute.
I say, listening to Carolina and Annie, you realize how lucky some of the pediatric patients are, because in many cases, pediatric patients, especially with rare and ultra rare diseases, don't necessarily have a specialist home. And that's a huge challenge. Many of them don't necessarily live near a specialty clinic. So that's another huge challenge. So there are, in fact, resources, but in fact, not everybody can get to them, either because of the condition they have and the diagnosis around that condition. And in fact, we have a lot of children, as you know, with undiagnosed diseases still, who end up spending a lot of time in emergency rooms, who spend a lot of time in complex care centers and not necessarily getting that kind of specialty care. So I think in some respects, as you say, it's a challenge. The other big challenge, as you know, is that we're getting more and more what we call the ultra rare conditions. And these are children who sort of halfway between the undiagnosed and those that have a diagnosis with a known condition, with a known set of guidelines, with specialists that they can actually be related to and have some kind of a care pathway that's been laid out. And in many cases, if they're very lucky, of course, they've got treatment. So it's wonderful that we're actually in some cases being able to diagnose these children, but the challenge is that they don't actually have a care pathway that's been laid out. And so, yes, even in the pediatric space, these children are oftentimes really, lost, and parents are actually quite lost in terms of what are best practices, what are ways in which they can get their children in terms of the multiplicity of the kinds of symptoms they may have, or even not knowing what those symptoms are, how do we get them properly taken care of? And beyond the clinic, as you know, I think as Annie and Caroline have talked about, there are physiotherapy kinds of issues. There are educational issues, so these children may have cognitive issues. There are definitely mental health issues. And again, those are not necessarily even in the hospital. They may be in the community, and yet, they can't necessarily get access to them. Sometimes because these services are listed by disease. So if you've got a known disease, you can get it. Sometimes they're actually just not existent, and certainly not existent in a way that's accessible to the children.
And you mentioned we're getting much better at diagnosis thanks to genomics, so we're getting better at treatment, and kids are living longer. A lot of these conditions was assumed they wouldn't live to adulthood. So talk about how's that transition work, especially for ultra rare. You might even not even know the condition, and suddenly they're adults.
Yeah, I mean, the good news is that we are able to diagnose many more using genomics. And sometimes the genomics can really identify what is the genetic, cause of this, what are the ways in which we might be able to treat some of the downsides of this genetic mutation. Sometimes you don't know it all and you don't have access to those services. It's always the good news and the bad news. Let me say something really kind of as we're moving into talking about transitions. In Canada, we have amazing pediatric hospitals. And they're just, among the best in the world. The problem is that, as you know, and as everybody's been talking about, they are limited to the pediatrics. And this is not true in every country. So I think, we can take a look at, certainly for some of these rare, ultra rare conditions, what have they been able to do? For instance, cystic fibrosis, hemophilia, newly now some of the rare blood disorders, muscular dystrophy. These are groups that have come in and have set up their own kinds of transitions, their own kinds of support that are not just bounded by the age or the actual institution that they're involved in.
Yeah, and we'll come back and talk a little bit about those, the way other countries are doing it when we talk more about solutions. And I do want to spend most of our time on solutions. So, Carlo, I want to ask you that. Dravet Canada is a group that's working on this transition piece in particular. Tell us a little bit about what you're doing to try and ease the transition for the kids in your group.
So thanks for that, Andre. There's a number of things we have on the go. It just started actually relatively recently. So we put together a new strategic plan in July, and our new executive director, Patty Bryant, is executing quite ruthlessly on this. So one of the things we've done is we've set up regional hubs. So in a Western regional hub, we set up a Quebec hub, Ontario hub, and an Atlantic hub. And these hubs are meant to service the geographical regions, because the support systems and medical systems are different across Canada. So this is meant to address that differentiation or that variability across Canada. At the same time, too, within these hubs are what we call mentors. So if somebody's newly diagnosed, or they're going through transition, or they're going through whatever part of that process, as I said, which is a lifelong process, who can we talk to about it? So we have volunteer mentors as well in those hubs. Again, this is really new. We're putting together registry, both a member registry and medical registries. So this way we have a good handle and can use that information to connect parents to each other, number one, and also to help us as we work with other groups such as GORD, to try and get support for these organizations. And we work very closely with other organizations as well. I know our executive director has been working with Durham for a number of years, which is really excellent. And we're speaking with other organizations as well. And the last piece we're putting in place too, which was asked during our planning session, is a roadmap. What can we expect as our children go down this journey? What are we going to expect pre-aging out, aging out as we get older, and putting that in place to give people a semblance of where they're going to land and what the journey looks like. In a nutshell, that's what we've got on the go right now.
Yeah, and Carolina, I saw you nodding there about the roadmap. That's ideally what every patient and family wants, right? They want a sense of where this is going.
Yeah, absolutely. And I think that's something, relate to what Annie and Carl were saying. Transition is a process. So although it's very, like at the age of 18, you're kind of switching from the pediatric side to the adult side. But I think one of the things that's important is really to start talk about transition earlier. So we sometimes try to start talking about the process with the family starting from the age of 16 or even earlier. So we can kind of prepare the families and the children of what's going to happen. And I think having in mind type of a roadmap, like what things needs to happen, like what type of individuals needs to be involved, what are the pieces that's important for each family, what can be done in the community, what can be done in the academic centers. So it wouldn't be like a very sharp transition. You turned 18, that's it, you're switching kind of sides. And really kind of preparing it. And I think it's really important for each child and family to recognize their different needs, because each family is very, very different and each child is very different. And some of them have different abilities and different needs. And if we wouldn't specifically address those needs, then we wouldn't be able to serve this family in the best way.
And you've helped a lot of children aging out, moving to the adult system. Where does it go wrong? What have you seen go wrong most often?
I think there are a lot of different challenges. I think one of the challenges is that the adult system tend to be a little bit more fragmented. So there's not like one piece that's coordinated, and many times you don't have like one individuals who would necessarily oversee everything. I definitely have seen children who have different needs of multi-systemic involvement and need multiple individuals like nephrologists, gastroenterologists, and then even in Toronto, sometimes they need to be seen in a different hospital. So they don't have physically one setting where they can go and everybody know their history. So if we'll take, for example, a child who is now 18 and a half, who needs to go to the emergency room, so not necessarily one place will be able to concentrate all of his care or know all of his history. And maybe I'll mention another piece is that we as a pediatricians are very familiar with those disorders. So we are familiar with the kind of more the concept of ultra rare disorders. And this is something that's much more rare in the adult population, again, because previously, unfortunately, a lot of those children were not surviving into the adulthood and were kind of staying with the pediatric care. So a lot of those kind of medical knowledge is more related to the pediatric world.
Now, Annie, you do transition planning, pre-transition planning, and I think you also use a roadmap model. Is that right?
Mm-hmm. So I work in an adult setting, and so part of the work that happens prior to patients coming to us, I'm not directly involved with. However, I have a counterpart that works at the Sick Kids Hospital that I'll work with in order to help prepare as best as I can. And then we, again, have lots of communication back and forth. But my understanding of how it works well is exactly like Dr. Gordetsky mentioned, is that it's this process. It starts early. If we think about transition as transferring independence to our young people as they age so that they become more confident by the time that they get to the age of 18, that they are then able to follow through with their medical care. Like we would teach our children to tie their shoelaces, to pick their clothes, to be able to get dressed on their own. And it's very, very similar. And we're not saying that it's this hard and fast, at age 10, you need to be doing this. At age 14, they need to be doing this. It really is very personalized because our patients are very unique individuals, obviously under an umbrella of a particular illness that may present in a particular way. And so it's really important for us to be able to balance out their individual needs versus those generalized needs.
And when I talk to parents, I hear them say, the medical transition is difficult, but the other stuff is way harder. The social welfare, the education system, just busing, things, practical stuff. Do you help them with that also?
I do, yep. So these are, again, conversations that we have with our pediatric counterparts so that the goal is that there isn't a gap in their care from the pediatric setting into the adult setting. And part of this has to be identified from the pediatric group because I may not know a patient yet. Now, there are resources that I can provide to our pediatric colleagues in order for them to prepare patients. I was invited to speak at an education day for a pediatric group last year, so that this is, again, things that patients and families are wanting to know about. What does transition look like? And so when we think about financial resources, are there things that they're going to age out with at the age of 18 that's setting this in place for when they're older in a financial resources or, again, busing, transportation, all of these pieces, if we can start asking those questions early, then we can try and mitigate that and not have that gap in between.
And Durhan, what you said earlier was a real teaser. We got some really good questions about it. So I want to read one of them from the audience. Pediatric hospitals have well-integrated care, including multiple specialties. Are there any examples of this kind of centralized care for adults with rare disorders that are happening in Canada or elsewhere in the world that we can learn from?
I mean, definitely there are some in Canada when we talk about the rare space, right? Oncology, of course, is one of those areas where it does happen. Transplantation, some of that happens. Hemophilia has developed, really good hemophilia clinics. Cystic fibrosis has developed their own set of clinics. So where you've got the patient community, the society, the organizations taking a role in that, you see that happening. For the most part, it doesn't. In Europe, for instance, when we think about the European Reference Network, some 27 networks that are organized around specific, rare disease areas, you do get that kind of transition. So they are not necessarily pediatric or adult, but they have specialists that can actually take care of it. Nobody says it's perfect, but they had started, many years ago with the notion of having these networks that not only are in one country, but because these are rare conditions, are able to actually work with hospital specialists, et cetera, across countries. We've also got some brilliant examples, for instance, in Brazil, where again, it's been sort of deep as opposed to wide, and they're able to take on a group, do the diagnosis, continue to manage them, follow them into the community, but you have to be deliberately set up to do that. And unfortunately, you have to get a whole lot of, resources and support, funding support.
And another question I think you'll love, because I've heard you talk about this before, the audience members asking, whose job should it be to make adult care less fragmented? Who should be making this easier?
Yeah, when I listen to Annie, I wish we had clones of Annie all over the place. I don't know how many people you actually get to see Annie, but obviously not enough. So that's brilliant. So the job may be whoever's doing clones these days, I think, should be the person that we want to go after. The training in terms of transition counselors, I'm really just delighted even to hear about it. It has to be the health system. I'll give you a quick example. We've got SMA is one of the great success stories of, the last 10, 20, 15 years, where we've got now therapies, 3 different kinds of therapies for children who, previously would have been very much severely disabled from very early age, now diagnosed early, can actually grow up living quite physically and, psychologically normal kinds of lives. But, the system falls apart when they become adults because there's nobody actually managing it. We've got a brilliant neuromuscular clinician who's trying to develop an adult clinic. And what he can't seem to find is anybody who wants to fund it. I mean, there's no monies for it. And so this is the challenge. We've got a brilliant clinic out in Calgary for kidney disease. Who's funding it? They have donations to fund it. We've got a great center that's the oncology center for a very interesting disease for VHL, von Hipp-Landau syndrome. Again, I'm asking her, how are you funding this? How are you managing to collect this information, do it? They've got they had a family where the patient died and they made a donation. So we cannot live on this. I asked Dr. Eisenberg, and just to squeeze this in because I'd love to give him a pitch. He's trying to set up an adult clinic for SMA. We never had this problem before because these children would die before they got to, young adulthood. We don't have a lot of older adults, but now they're on treatment, a lot of them. Managing this treatment is not easy. Also, their disease continues to progress even on treatment. So who's going to take care of them? I said, what would it take? He's got a donation. He's got a grant that's helping to fund this clinic, but he's running out by the end of this year. And I said, what would it cost to do it? He says, it costs the same as one vial, one dose of the drug. And so if we're not having that one dose of drug, these patients are absolutely not able to take best advantage. And yet we can't find who to ask to. He says, who do we go to? We can't figure it out. There's nobody really to ask.
Yeah, kids living longer should be a challenge that we relish, I would think. Now, Carl, I want to talk to you about one specific part of transition, kind of an issue that I'm obsessed about, data. Patient records. When you're a child, the hospitals are pretty organized. The 17 pediatric hospitals have really good records. The rest of the system, not very well integrated, not a lot of interoperability. Talk about the records part of the transition and how that maybe made your hair a little grayer.
Yeah, it was brown a couple of years ago and down to my shoulders. Well, I'll put it this way: in Ontario, or in the Ottawa area, in Ontario, my chart is basically almost the standard, right? We have 3 my chart accounts for our daughter, 3, not 1. There's not a patient record. There's 3 separate accounts, and we're not sure about how well they're connected between them. I do know in the transition we did have some challenges getting our new neurologist access to her records. And when you have a child who's got all these, as Dr. Gorodeski had mentioned, Annie mentioned, Durhane has mentioned, they've got all these other challenges. There's also issues such as allergies, whatever. And if there's an emergency and your child goes there and they have no records, it could be catastrophic. So getting those records across was a bit challenging on our part. And to the point that I actually had to write a very polite letter, email to the CEO of the hospital saying, why can't her new neurologist access her records? Now, again, this whole renaissance of EMRs, electronic medical records, and the use of MyChart is relatively new. So I believe there's better integration now, but I would still ask, why isn't there one record? Why don't we access it in one spot? And why is it not identical? The 3 MyChart systems are all different. They have different information. They're probably connected. And Dr. Gorodeski, I'd love to hear from you if the records are in fact connected, because we're not accessing it. We're just on the other end of it. But that was not entirely seamless, and it should be a little simpler. And her GP has a separate data record.
Yeah, maybe Carolina, you can address that as a doctor.
Yeah.
Sorry there, Carl, you froze up. I thought you had stopped. But I want to ask Carolina, do you have that issue as well as a physician with records? I imagine that's challenging. I know the children's hospitals are very well integrated, but beyond that.
Yeah, so I mean, Carol, I completely agree with you. I think that this is also one of the motivations why, we really wanted to have some more transition clinics. It's just to make sure that all the information will be transitioned to the adult side. It's definitely much better now than it was a few years ago, because a few years ago, most of the hospitals had a completely different systems, and a lot of it and some of it was not electronic. And I think a lot of the hospitals now transitions into electronic medical record systems that they are connected to some extent. There are still a lot of places in the community that they're not connected to the same system. So I would think that children who will be transitioning in like 15 years from now, it will be much better. But for the children who transition now, their information started 18 years ago, right? So we are talking about still, in the next probably like 10, 15 years still, in the cohort of children who were still kind of born into the era when we did not necessarily had this integration in an electronic medical record. But that's really, really key point for our adults colleagues to know.
And Carolina, I want to put in another audience question your way. The person is saying chronological age can be really meaningless with disorders that affect cognitive functioning. Should some patients just stay in pediatric care forever, regardless of their chronological age?
So I think that's $1 million question, and
it's probably $1 billion question.
Yes, why not? We can ask for $1 billion. I think I completely agree. I think that's the chronological age. It can be completely meaningless in some of the children that we follow. And this is very arbitrary, like 18, nothing changes between 17 and a half and 18 and a half. The children still have exactly the same needs, exactly the same approaches. And this is more, how do we view our medical system? But the other question comes, okay, so if you'll keep all of those individuals in the pediatric world, what will happen when they will be, 40s, 50s, 60s, when they actually do have more adult-oriented medical problems, which I'm, as a pediatrician and, pediatric neurologist, I don't have enough knowledge of how to treat individuals when they are kind of in their 50s and 60s with those problems. So I do know that some of the centers in United States, for example, when they have children with ultra rare conditions, they tend to follow them longer. So definitely above the age of 18. But even in this case, at some age, they will decide that, when they have more of the adult-oriented medical problems, that they actually need to transition them.
Yeah, I guess there has to be a cutoff point at some point, and we have to figure out the right one. I want to turn to Annie. I'm looking at the question. There's such great viewer questions. I'm throwing my questions off, but someone's asking about red tape. They're saying essentially, it's way harder to do everything when you're an adult than when you're a child. Getting disability benefits, psych assessments, stuff like that. How do you help people wade through that red tape, which can be quite onerous?
So when patients are coming to us from the pediatric setting, we start having these conversations about where challenges lie. So let's say, for example, a patient is having drug coverage under their parents or under their caregivers. And so that is in place up until a certain age. And so we start building their health literacy around understanding what's available to them, how to access resources, how long that's going to be in place for. If it's not going to be in place, we give them education. But it's not this dump of information, because sometimes it's just too overwhelming. And so the bigger support that I provide is trying to help patients ask questions, get to the place where they know how to ask questions and to be able to direct them to the places that can answer them. Sometimes it's just posing them to their healthcare team saying, I'm struggling with this. How can you help me with this? When we talk about red tape, yes, there is going to be red tape in every institution that we deal with. The question is, we don't give up. We just keep going. And it may just take longer than it may have before. And so when you have advocates and supports to be able to write letters on your behalf, to be able to follow up, I think that's the biggest piece. But we recognize that families and caregivers play a huge role in the push to continually advocate for patients in their needs. So people like myself, a social worker working in a hospital, can help support patients in this situation, but it's, again, developing that partnership with our patients.
And Durhan, I want to come back to an issue Carl raised earlier, essentially the aging out of parents, that they get older as their children become adults. And I want to read this, a long comment from a reader, but it's very touching. So I want to read it and let you comment. Some rare diseases will touch on more than one specialty. My son has a neurologist, a nephrologist, a pediatrician, and has interacted with people like geneticists over time. The transition as a single change is kind of a misconception. It's more like a number of transitions at once, and our concern is not the existence of adult specialists, it's the effort required to recreate the support network for a person who might not be able to care for themselves. And then finally, the kicker. One day I will be dead. It will be up to someone else to manage my son's care. How do families approach this problem when they remain a caregiver?
I wish I had an answer because that is a very common problem, I think, as Carl and others can relate to. And it's even more than that, it's financially as well. I mean, a lot of things can be taken care of when you are a child, but as you get older, the needs become more difficult, more challenging. And parents that are oftentimes supporting financially their child as the child gets older into adulthood, obviously they're not going to live forever. We have some amazing parents who have been able to set up things like trust funds and been able to have ongoing support, anticipation for when they're no longer there. It's that curse of what we say, the more we do in terms of being able to help children survive into adulthood, but not necessarily to be free entirely of their condition, the greater the challenge is going to be in terms of being able to assure that they're not only going to get access to the specialists, but to be able to have the access to the other care. Once upon a time, Ontario actually had a pilot program in which they tried to support young adults who were, this is one, for instance, I had a very good colleague, her child had Prader-Willi. Now, most Prader-Willi children may not live to be very long. This child was actually living and doing very well. The government had a support program where they put her into a supported living environment where she had a lot of supports to actually help her in terms of being able to live there. It was meant to be a pilot project. After they did the pilot, as with many great pilot projects, nothing was ever done to extend it, even though it was a brilliant success. So I think we know how to do it in this society. We just don't put the resources there in order to make it happen. And I think this is, again, kind of, when the rare disease drug strategy came forth, we had hoped that it wouldn't be just for the drugs. It would be for everything else around the drugs. And this is one of the things that we say. The monies has got to go across the needs of the families. And I think it is, exactly as everybody says, not everybody has a Carl as a father who's going to be able to do that. Not everybody has the kind of ability to actually take on their own care. So our system is not designed to actually look beyond kind of what is there. And again, I point to, places that do have these integrated networks that are able to look beyond just the care for the clinical needs and to look at what else is required beyond and to help put it together. What we don't have and we've asked for is navigators. And these are people who can help support the patient and the family. Some, again, patient groups, have the Huntington's disease. Again, they get very little support, very little treatment, though we know that there's a gene therapy coming, which is so exciting. But they've gotten very little support there. They've had to do this themselves. Muscular dystrophy for a very long time didn't have much, so they had to do it themselves. So I think where there's a community to help do it, it's great, but it's not sufficient, it's not forever. And I think, as Carl says, when you're trying to think about many of the families, they don't have that support. And, the few clinics that I know that have done it well, they rely on, unfortunately, families that have passed away that donate the money. We cannot live on a system that requires on, the patients dying and getting a fund out of it. So we do have to support it. And I think what the research shows over and over again, if we don't support them in terms of the broader needs, then we have, I won't say wasted, but we really have not been able to take full advantage of what they've been given. And I can imagine that people like Carolina, when she, sees her patients, it's like, what am I handing you over to? And that feeling of, I've got my baby and I'm trusting you over there. But, they're not going to get fully that kind of support. And it's a scary thing. I mean, we see it over and over again.
Carl, you mentioned earlier, Alyssa is going to turn 23 soon. You've been taking care of her whole life. When you look forward, do you imagine who's going to take care of her when she's 40 and 50? Who's going to be there?
That's that's the $2 billion question. So, we're still grappling with that. A lot of families with Dravet are still grappling with that. And as Doreen said, other rare disease are grappling with that because we've said it several times, we weren't expecting our kids to last this long. So there's a number of different things that are going on. And I want to go back to a point that Annie had made before, is that it depends on where the children are in the spectrum. Can they take care of themselves? A lot of parents are looking at things such as co-ops and setting up not-for-profits and housing and everything else. In the case of the children that need 24/7 care, need to be with arm's reach, that option doesn't work. So Durhane said it, the standby is a trust, Henson Trust. Set her trust up a couple of years ago. There's not enough money in there to keep her. There won't be enough to service our daughter's needs for a while. So we're still trying to figure out how to do that. We've met with several parents about this. People are, we're setting up our house. The house is the easy part. The capital is the easy part. It's the operating that's the hard part. Finding the workers and everything else is really, really, really difficult because they're just not there, and it's horrendously expensive. We looked at a couple of years ago, looked at a group home, and we sat down. They had a spot for Alyssa. It was great. It was fabulous. It was great. We sat down. She loved it. It was like, oh my God, it's around the corner. We knew the people that ran the home. And then they said, how are you going to pay for it? So is it covered? He said, no, it's not covered. How much does it cost? And it amortizes over to about $500,000 a year, unfunded. And the price has gone up now. Like, it's more expensive now. So that's untenable. You can't do that. So we, as Durhane said, we don't have solutions. Actually, I want to relate a story, and maybe Annie, you've heard this as a social worker. One of our parents basically said that was asked with the community social worker, what happens when you can't take care of your child anymore? And her response, honest to God response was, well, we all sleep, the three of us sleep together in a large king bed, and we're just going to die together because we have nothing else. And the social worker didn't believe it, said, that's all we have. That's all we have. So we've been encouraged by a couple of people, get your child into the hospital and refuse to take her home. That's an option. That's a serious option parents have taken. As Durhane said, there's just not enough out there, and sorting. And it is relatively new because we weren't expecting our kids to last this long, but we don't have solutions. We're trying to do it the way I do businesses and raising money ourselves. But other than that, there's a lot of people who don't have that capability, and it's a real problem. Very serious problem.
And Annie, I hear many of those heart-wrenching stories about, I'm just going to have to leave my child at hospital, etc. Is there enough support for parents today?
I think this is a challenging question because I think it's limited. I think the resources exist to some degree. I think it's a matter of how much people can access. Resources change all the time as well. And so it's important for people to be on top of what's actually available. Again, funding resources are there, but then they get maxed out so quickly. And as Carl just mentioned, things don't stay the same price. Things continue to go up. And as our patients are aging, that care is now required for longer and longer. I think resources are one piece of it, and the second part of it is just our patients and their families and their ability to continue to advocate and to continue to fight. And obviously our patients and our families are, because it's something they need to do, but it's exhausting. And so a lot of that care that we provide is helping patients navigate, but also providing support to the family members, to the process itself, recognizing that sometimes there's limitations.
Yeah, it's a question we need to ask more. Who's going to care for the caregivers?
100%.
And Caroline, I want to come back to something you had said earlier about, there's about innovations in medicine, how we're getting better at treating. There's some positive stuff there. Are there actually kids who aren't going to need care their whole lives anymore because of, we forget about that we've made progress?
You read my mind. This is exactly what was, running through my mind when I heard everyone, and, just reflecting that I think the challenges that we were talking about, we will, for better or worse, we'll have more and more of those challenges because we're living in very, very exciting times where there are new exciting treatments on the horizon. So the SMA, for example, was mentioned as a great success of a gene therapy for children who usually died in the first 2 years of life, and now, can live a, almost normal life, or, definitely survive into the adulthood. And now in the pipeline, there's many, many more genetic therapies. And I'm sure, Carl, you know about the Dravet gene therapy. Again, it's everything in the research stages, but it is something that we feel will be there very, very soon. And we are really, really hopeful that those therapies will be helpful for the children we treat. But this is also, in a good way, means that they will be more adults with those ultra rare conditions. So those challenges will be kind of more frequent.
And these drugs, these genetic therapies can cost $1 million, $2 million, but we don't often talk about they may save $5 million, $10 million of the cost of someone's life.
Absolutely. And a lot of those treatments are very expensive. I can share with you that I now treat for a child with super, super rare condition, that there is a gene therapy existent. And when we chatted with the company, so the number around it was around $6 million. So it is something that can be quite expensive.
And Durhan, I know I can't resist asking you, you know this issue well. It's not just about the cost, right? It's about the investment. It's about the savings down the road.
Yeah, it'd be great if every disease could have a gene therapy. I mean, I think we could pony up and figure out how we might amortize that payment, because it's going to save, at the end of the day, a lot more than $5-6 million. And we've had families that have raised $5 million to do the gene therapy because it's a one-time time. The challenge we have is that many of these therapies are lifetime therapies, and they are very expensive on an annual basis. And some of them, because they're weight-based, as the child gets older, they're going more expensive. So we've got to design a system that's actually able to accommodate that. And one of the things I said in one of the early notes I sent over, one of the challenges is that we do not have really good access for adults. Some of these are pediatric conditions, but you also have adults that have that condition, and we deny the adults access to that treatment because we don't have necessarily the basic clinical trials around it, et cetera. So I think these are very, very expensive therapies. I will say we have a $1.5 billion rare disease drug strategy that the federal government funded, and it has made a world of difference for those drugs that are within that, what they call the common list of drugs. Those drugs are being made available. Those drugs are being picked up by the provinces. Those drugs are being accessed by families. But that's the kind of commitment we have to make, is to say these therapies are there and we need to be able to make them available. But, many of them are going to be lifetime treatments. And I think that's sort of a bigger challenge, but in the long run, as we're all saying, there is a return on that investment. We just have to be willing to say, okay, we can make the investment. And I will say, Canada has actually demonstrated that if we invest in it, we can make them available and that they are really benefiting patients. Now, what can we do in order to make sure that we can leverage that funding to be able to make, as these therapies are coming in, to make them available as soon as possible to patients?
And Carl, I want to come back. I'm trying to come back to questions I skipped over because I went to the great audience questions. I want to come back to this. It gets sticky after age 18, 16, 18 about parental involvement. How do you as a parent balance that? You want your child to be as independent, to live to the best of their abilities, but also, you want to take care of them. How do you find that balance? It's a little more difficult when your child has a serious medical condition, I imagine.
Actually, we drive it. Like, we take control of it and we're in charge of it, just as if she's pediatric, end of story. Like, we don't see that demarcation of 18 is just a number, as Caroline had said, it's just a number, nothing else. It's arbitrary. So we take control of it. We're in charge 100%. And it's not really a balance. We've been balancing things for 20 years. So when I made a comment right at the start that it wasn't bad, that's because we're really resilient and tenacious because of what we've gone through. Other people seeing, with regular children would go, oh my God, how did you do that? So it's just the way we are and the resilience we build up. I'd like to go back to a comment that Durhan made about cost, and just circling back a bit, because there's another aspect of cost that people don't consider, is that, and again, we're at the front end of this, and the cost is a lot of parents are dropping out of the workforce. Highly productive people are dropping out of the workforce. That's costing Canada quite a bit. We don't know what that is. As for any academics listening, we can ask the master's study, but there's a benefit to that as well. There's a benefit as well, what it's not going to cost if our kids don't need this, horrendous amount of money to take care of, right? So there's that piece of the balance as well, cost benefit. If you take a look at that, I suspect you could probably get a zero-based sort of approach to this. Sorry, I went offside a little bit, Andre, because I think it's important.
Yeah,
Andre,
no, it's an important issue.
can I
to
jump in
find.
for a second, Andre? I
Yep,
know you're
yep.
really doing a great job in driving it, but I just need to pick up on what Carl says, is that we have just completed our second socioeconomic cost of impact of, we tried to not use the word burden. It was called socioeconomic burden of rare disease, but it isn't really, I mean, it is a burden from a financial point of view. So we are beginning to get a really strong sense of what Carl was talking about. What does it cost in terms of families and patients for living with rare conditions? What does it cost the healthcare system for living with it? And what we're trying to get to is what does it cost it and what can we save by being able to properly care for these children and adults, by providing them access to treatment. I don't know that it's a zero-sum game. I don't know that we will actually ever be able to say, okay, the return of, as you say, the indirect cost, dropping out of the workplace, having people that actually have to be caregivers and the cost of that. But I think it is very costly, and it's important to demonstrate what those costs are. Other countries have done it, and I think it sort of helps us to recognize the huge impact. Can I just throw in very quickly two other real things I just want to say? In many countries, not many countries, in a few countries, I don't know why I said many, in a few countries, rare disease is not treated as a patient issue, it's a family issue. You look at, there's a wonderful center in Perth, Australia. Rare diseases is a family business, and they treat the whole family. And this is taking it, including, the needs of siblings, etc., but also how to help families. The other thing that's really valuable, and what Annie says, we've got a wonderful center, for instance, in Sweden. This is a center that's actually for families to come in, or teens sometimes come. It's a retreat. Families have a retreat. Parents can come in for a retreat. How do I continue to take care of my child or my older, adult at home? Here's a retreat that you can go to. You meet with other families. You kind of learn from each other, etc. So I think if we step out of thinking of rare diseases as affecting a patient, but realize that it affects the family, it affects the extended family, and can we care for the whole family who are oftentimes really pressured as much as that individual patient? I think, again, that's where that integration comes in. And it's a mindset. We can do it. We just have to look at it very differently. I mean, Carl, you're the living example, right? Dravet doesn't affect your child. It affects your whole family. And the solutions you're coming with are family solutions.
And related to that, there's an audience question. Maybe I'll send it Annie's way. Can you suggest any community resources or networks to help caregivers and patients feel more included in society? How do they break out of that isolation that often comes with having a child with a rare disorder?
Well, there are caregiver networks around particular disease groups. And so if a patient and a family is coming to me with this specific question, I would be looking around a resource as narrow as we can to try and find the resource that meets that family's need. Now, if there's a larger, broader group, then I would connect them that way. Sometimes it's helpful even just to do like one-on-one. We have mentorship type of programs that run through our program at the hospital. And we will connect patients and families who are struggling around a particular issue and then helping them navigate the process together. So it's sharing information, ultimately, what other people have learned in order to help them with their next step, because now they're through it.
And I'll mention there is a Canadian Centre for Caregiving Excellence that does some great work in this field. Now, we're almost out of time. I always like to end panels on a hopeful note. I always try and do that, especially in these times that are not always particularly hopeful. So I want to ask each of you, maybe in 30 seconds, tell me how you think the situation is going to improve, how we're going to get better at transition from pediatric to adult care. What's making you hopeful? Carl, do you want to start us off again?
Sure. And I think people have already stated, I'll just reemphasize that. We're at the front end of this. Our kids weren't expected to live that long. That's why it's bumpy. It's always bumpy when you're starting on one of these journeys. So the fact that we're having this discussion, more people are asking questions, I'm pretty hopeful that this will be sorted out in all dimensions, even as Carolina has said, even on the new therapies, et cetera. Because we're in the front end, we're just in the start of the journey.
Yeah, you're pioneers. You're learning the hard stuff for everyone else. Carolina, how do you think things will get better?
Yeah, I think from healthcare providers, it's definitely a topic that's everybody, more think and talk about it. So it is something that's at the kind of thoughts of the pediatric providers as well as adult providers. So I think that there's a lot of great work that's already happening, and there are small steps, so maybe baby steps that's happening, but there's still very long road. But I think we can, like by raising those questions, talking about it, is definitely something we can do together.
Annie, in your work, you give families hope every day. How do you stay hopeful?
Well, I think the fact that we're having conversations like this is really helpful. The fact that we're now listening to more than only the clinical piece. We're listening to families, we're listening to the issues that patients are facing that is not only clinical. And I think, Durhain, it's that family part that we may have missed earlier on, that I think people are they're hearing now and listening, and responses are based on that. So I think this collaboration part, I'm really hopeful for.
And Durhain, I can always count on you to end on a hopeful note.
Money. What we need is funding. We are so excited by the fact that we have this Canadian Rare Disease Drug Strategy, $1.5 billion for 3 years. We're now talking about what phase 2 look like, because we know there has to be an investment in terms of advancing, taking advantage of the therapies, taking advantage of the models that people are having. But beyond that, what's been exciting about this strategy, and I can tell you, I was highly resistant when it started, is how do you get monies from the federal level into the provincial level where the actual, healthcare is being delivered? How do we put up guidelines? How do we hold accountability? I think we're learning through this first 3 years of it, what works and what doesn't work. But we definitely need, cancer control strategy wasn't say, okay, we'll give you monies for 5 years and goodbye, cancer's done. Same with rare diseases. We cannot just say, okay, here's your 3-year, kind of experiment that we gave you. Goodbye, we're gone. We need to be able to continue it, but we also need to do kind of what this conversation is about. How do we bring all the stakeholders into the conversation to be able to provide the right kind of advice? And I would beg some of you to work with us. We're trying to do an evaluation on it out of the implementation advisory group. We have to say what worked, what else we need to be able to do, how do we hold accountable? So I've been thrilled with this conversation. It really has given me a lot of hope in terms of what the resources there are there, not just in the hospitals, but in that clinician, social community, but especially with Carl. You're exactly kind of what we unfortunately have to rely on, and that is families that are actually taking on the task and paving the road for all of us. So we will follow in your wake, my dear.
And I think it has been a rich and useful conversation for the audience. And Durhain, I think you ended on a very good note. Invest in our kids, they're worth it. So I want to thank our panelists, Dr. Karolina Gorodetsky, Carl Weatherall, Annie Thomas-Deisman, and Durhain Wand-Rieger for being there today. On behalf of the Globe and Mail, I also want to thank Acadia Pharmaceuticals for making today's event possible. They're our sponsor. On your screen, you'll see a QR code. Please scan it and fill out the post-event survey so we can continue to improve the experience with these webcasts, which we do quite regularly. We'll also send you a survey by mail in your email. The other thing you should watch for in your email is a link to the recorded webcast. Everyone who is registered will get a link so you can watch it again. You can share it with friends and family. Even those who didn't show up today but who registered will get a link. So it will be there for everyone to enjoy and learn from. Thank you again for everyone for tuning in, and stay well.